In this video, I'll be answering viewer questions. Don't turn away, because that starts right now. Hey! Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. I love this growing global online village that we've created, and I love reading the comments and questions that you leave. And today, I'm going to be answering some awesome questions asked recently by viewers. So let's jump in. Philip Barton writes, Dr. B, my daughter had her first Lemtrada treatment 12 months ago here in the UK. She was due to start her second round next week, but the hospital just postponed it as they could not guarantee her safety due to the escalating COVID-19 problem here. This could go on for months. My question, will any substantial delay in administering the second block of Lemtrada reduce its effectiveness? Well, Philip, my heart goes out to you and your family, and my best wishes to your daughter. I have had this exact situation with several of my own patients that I'm following in clinic today. We're faced with a situation where a year ago we gave Lemtrada, and now it's time to give the second dose, and there's a global viral pandemic. And so what we have opted to do on a case-by-case basis is evaluate the risk-benefit. I'm literally talking with patients on a monthly basis as we review their laboratories and as we take stock in the current COVID situation here in Central Ohio. Now, some patients we've opted to dose them. In other patients, we're waiting. And in some cases, we're waiting months. I think that the answer to your question is actually not known, in that I'm not aware of any clinical trial where we gave patients 5 days and then nothing else. It is my opinion, looking at the cell lines, that things don't quickly reverse at 1 year. You still have a suppression of some of the immune response, and more importantly, you still changed those immune cells so they're behaving differently. That's maybe a long-winded way of saying I think delaying the next Lemtrada infusion by a couple months is probably generally okay. It's incumbent on us to evaluate the specifics of that patient situation and the specific COVID situation at the time, and then to decide, is it time to pull the trigger or not so much? I wish you and your family the very best of luck, and thank you for the question. Laura Irons, Talks MS, asks the following excellent question. Everyone always says Campath is a chemotherapy. Can you tell me if that's right? Laura, great question. I want to dig in because it's actually a rather complex question. So first of all, what is chemotherapy? So chemotherapy is defined as a drug treatment that uses powerful chemicals to kill fast-growing cells in the body. Okay, so why does chemotherapy work to kill cancer? Because cancer cells are cells from your own body that are growing way too quickly. So all cells make new copies, but if a cell does it way too fast, it makes a bunch of copies, and that is a mass of cells. That's a tumor. And so chemotherapy, which kills rapidly producing cells, can kill tumors. Now, when you think about traditional chemotherapy, and you think of like a cancer patient that gets hardcore chemo, oftentimes they have side effects. They lose hair in some cases, they can have diarrhea and slough their gut, and they can be immunosuppressed. Why? Because all the cells I just described also reproduce rapidly. Your hair cells grow quickly. Well, maybe not mine, but other people, their hair cells grow fast. And cells that line the gut reproduce quickly. And the immune cells also reproduce fast. So when you give chemo, you can knock them out. Well, think about it. If we can give chemo and inadvertently suppress the immune response, we could use suppressing the immune response to treat an overly active immune disease, an autoimmune disease like multiple sclerosis, which is exactly what we've done with the drug you're asking about. So check this out. The actual drug name, the generic name of the chemical compound is alemtuzumab, right? So alemtuzumab is the drug. It was studied to treat a form of cancer and FDA approved under the trade name Campath. Separately, it was studied given intravenously to treat an autoimmune disease, MS, and FDA approved under the name Lemtrada. So is Campath chemo? Kind of. It's a very selective form of chemo. Is Lemtrada chemo? kind of, not really, because it's selectively ablating the immune response. The reality is that the term chemotherapy is a bit outdated, and it harkens back to the era of Cytoxin, when we give poisons that just knocked out the immune response. And at least in my field of neuroimmunology, we're starting to embark on a world where we have very, very selective therapies like alemtuzumab, which specifically knock out slivers of the immune response with outstanding benefits. So thank you for asking the question, Laura. Metroplex, the Uber driver, asks, Ocrevus or Tysabri, what's the difference? Would you suggest one over the other? Well, Metroplex, the Uber driver, first of all, I dig your name. Second of all, if you're having a discussion about Tysabri or Ocrevus, you're discussing two of the three most effective drugs that I think exist currently to treat multiple sclerosis. So in some ways, it's kind of like saying Ferrari or Lamborghini. They're both really good cars. If you randomly picked one of those two drugs, you're picking a most outstanding drug. Of course, yes, they're different. And what I have found is, in talking to individual human beings about the specifics of each drug, we very comfortably find one that makes more sense than the other. So I can't list out for you, this is the person who is always right for one drug, and this is the person that's always right for another, because that doesn't exist. I want to focus on the fact that you're talking about two of the very best drugs that exist. And if you gave me a Lamborghini or a Ferrari, I would be okay with either. Spencer Cooper asks, Aaron, how do you feel about patients recording their visits with you? Is it an acceptable thing to do? Does it vary by doctor whether they allow it? I haven't done this with my neurologist yet, but I couldn't think of a better way to take notes than having a recorded record to review later and transcribe into my records. Well, Spencer, thank you for asking that question and laying it out so clearly. And I think that it is completely reasonable to ask your neurologist or your provider of any medical subspecialty how they feel about that. And I think it's a very appropriate question to ask. Now, I can only give you my own personal answer. I can't answer for another doctor. For me, I am completely against it. I will not allow it at all. And I feel very passionate about this. Now, when we're in the room together, if you want to take notes, you're welcome to. If you want to bring a friend with you to take notes, you're welcome to. I will take detailed notes while we're talking, and I will give you a copy of your note. So you have exactly what I have said to you and what I think. And I give that to you in writing at the end of your visit. But I am very much opposed to being recorded, both in the office, in person, and on telemedicine. So that's my take on things, which doesn't make me right. That's just my preference and the way that I practice in my clinic. I will share that I'm not aware of any colleagues that have felt comfortable being recorded in the past. But that doesn't mean there aren't some that are out there. My buddy, Dr. Brandon Bieber, asked the following question. What percentage of your patients with newly suspected MS are you getting a spinal tap in your clinic? Well, first of all, thanks for the question, buddy. And for those of you that aren't familiar with Dr. Bieber, you should check out his YouTube channel. The guy's awesome. He puts out a weekly YouTube video on multiple sclerosis, and he does it every Wednesday. So definitely check out his channel if you haven't already. Now, to answer your question, Brandon, I don't do it very often. And I would say that we're probably getting a spinal tap on way less than 20% of patients. If they are meeting diagnostic criteria without the tap, then we're not getting it. I happen to know that Brandon works at Kaiser Permanente out in California, and so I'll reverse the question and ask you, my friend, how often are you getting spinal taps in suspected patients? Maybe you can answer me in a video. Take care. Crystalline asks, how soon after the initial signs of a relapse should you ideally get treated? That's a really good question. And I will put a link up above to a card where I talk specifically about relapses and when to report. But in a quick nutshell, if you have a new neurological symptom, which lasts longer than a 24-hour period, I want you to call your MS provider. And it's my expectation that they would see you. And one of the things they need to do is rule out a urinary tract infection and start treatment. Now, what your specific question is, how quickly should you be treated? And in my opinion, the earlier the better. Is it impossible to treat someone a couple months into an attack? It's not impossible, but the likelihood that we're going to get a robust response is way, way, way less than if we jump on it early. I would ideally like to treat an attack within its first week, all things considered. Thank you for the question. In case you're wondering, it is summertime in Ohio, and it is super freaking hot outside, and I'm sweating, and I'm sorry about that, guys. But it's a nice, otherwise, place to be, and so I hope you'll put up with a little perspiration while I answer these questions. Richard Lee asks, "Hey, Aaron, it's Rich from the UK." Well, howdy, Rich. How you doing? Another great video. Thank you. I have a question. Why don't we take more than one disease-modifying therapy? If some work differently than others, why not take more to increase the chances of fewer relapses, etc.? Rich, this is an awesome question. And combination therapy is something that has been minimally studied in the field of MS. And to date, combination therapies in clinical trials haven't really worked out for us. But I don't think that means they wouldn't work. And in fact, if you look at other fields like oncology, rheumatology, infectious disease, they have been extremely successful in knocking out their respective diseases by stacking multiple therapies up at once. I really think of the future as using three kinds of therapies to treat MS. The first of the three would be an anti-inflammatory drug, like any of the 22 FDA-approved drugs to treat MS currently. They're all different flavors and strengths of anti-inflammatory drugs, and that's one of the ones that we need. But we need two others for the three. The second one we need doesn't exist yet, and that would be a remyelinating agent. And we are currently actively studying multiple different remyelinating agents, and I think in the next several years we're going to have one. And it would be reasonable to take an anti-inflammatory and to add a remyelinating agent to it. Now, the third therapy also doesn't yet exist, and that is a neuroprotective agent to prevent the pool from draining the water, so to speak. And we don't yet have a neuroprotective agent. And there are some hopeful agents out there, but we're just not there yet. So it's my prediction that in the future, we absolutely will stack drugs. But we won't stack three anti-inflammatory drugs. We'll stack an anti-inflammatory drug, a remyelinating drug, and a neuroprotective agent. Just my opinion. Thanks for asking the question. Hey, do you have a question? Leave it in the comments section below, and I'll look forward to reading it and answering it in a video just like this. My name's Aaron Boster, and thank you for learning about MS with me. Until my next video or my next live stream, or the next time I see you in clinic, be safe and take care.